Welcome to the Office Hours Quality Payment Program conference call. My name is Erin, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star then 1 on your touch-tone phone. I will now turn the call over to Mona Matthews. Ms. Matthews, you may begin.
Thanks, Erin. Hello, everyone. This is Mona Matthews. I am a project specialist with Lake Superior Quality Innovation Network, serving Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I would like to welcome all of you to this session of QPP Office Hours. Today's call will be operated assisted. By default, everyone's phones are currently on mute to avoid background noise. Since this is an open office hours call, there will be opportunity to ask questions over the phone, at which time our operator, Erin, will provide instructions. We will also be closely monitoring the chat box and encourage you to post questions or comments throughout. Also, please note that the information provided during this session is based on the latest information made available by the Centers for Medicare and Medicaid Services and subject to change. CMS policies do change, so we encourage you to review specific statutes, regulations that may apply to you for interpretation and updates. And there will be a link, there should have been a link to the slides made available on the WebEx page. If not, we'll get that into the chat here as we go along. At the end of the office hours, you'll have the opportunity to complete a brief evaluation. We would appreciate your feedback about the event and suggestions for future educational opportunities. We would also like to remind you that when you receive technical assistance related to the QPP, to please take time to complete the evaluation at the conclusion of each technical assistance. Your feedback is very valuable to us. Also, I would like to mention that during the office hours call, we typically get to address a broad range of questions, which are based on an equally broad range of QPP MIPS knowledge level of our call participants. Some questions we may have to research a little bit more, and then we'll get back to you with the answers. Our team has implemented the process to capture all the Q&A presented during these calls. Questions that our team deems broadly appropriate to all of our audience will be emailed to the participants within 2 weeks of this event. Those that are scenario specific, our team will address directly with the attendees via email or by telephone. Finally, questions that require a little more research or those that appear frequently will be addressed at our next office hours. So with that, I'll get going on our didactic session of this office hours. And just as a disclaimer, and this was mentioned in my opening script as well, we'll do our best to answer your questions, but obviously things do change, so make sure you're looking at the statutes. So we do have a few objectives for today. We're going to provide quality payment program updates and new resources for successful participation in reporting. I'll spend a little time, just one slide, on summarizing some important deadlines, and we'll provide an opportunity for Q&A, and that's the main portion of our webinar today. So just a few important dates. As of right now, we're being told by CMS that July 1st, you will receive performance feedback. So the window to report your 2018 data, as all of you know, closed at the beginning of this month, and then you'll get feedback on July 1st. Spring 2019, and I don't have an exact date on this, but the QPP exception application window opens. So if you are looking to file an exception application, watch for that opening coming up spring 2019. March 31st, 2019 is the first snapshot for qualified participant or QP determination, and Merit-Based Incentive Payment System, MIPS Alternative Payment Models, APM participation. And July 1st will be the deadline to register for the CMS web interface and the CAPS for MIPS survey. This is really the only registration you do for MIPS, and if you don't use the CMS web interface or the CAPS for MIPS survey, there aren't any other registration. We're still waiting to hear how the opt-in process will work, and if there's some sort of registration, we'll keep you updated on that, but at this time we don't have any update on that. So today I wanted to give a little bit of information about the cost category, so we'll focus a little on the cost category. I want to remind everyone that during the open office hours after we go over the didactic session on cost category, you can ask questions that are related to cost or any other portion of MIPS. The review of whatever category we review at these office hours does not have to dictate all of the Q&A. So just some of the basics about the cost category. The weight to the final score is the default rate, and is 15% of your total MIPS score. It does incorporate many of the components of the value modifier or VM program that was part of the legacy programs that CMS had. There is no submission needed for the cost category. This is all based on your claims. This year there are 10 cost measures. For those of you that participated last year, you'll remember that there were only 2, and they're the first 2 that are listed here. The total per capita cost and the Medicare spending per beneficiary. In addition to the 2 that were in effect last year, CMS has added 8 episode-based cost measures. So the cost performance category, the weights have changed in the first 3 years of MIPS. So during the first year, the cost category was weighted at 0. So you would have received some feedback on the cost category last July based on your 2017 performance. This year for the 2018 performance year, the cost category is weighted at 10%. And again, there were just those 2 measures that were in effect last year, the 2018 performance period, and that will affect payment year 2020. Now this year, the cost category goes to 15%. In all performance years, the cost performance category is assigned a weight of 0% for MIPS eligible clinicians scored under the APM scoring standard. The source down at the bottom of the page, and we'll get this posted into the chat as well, is from the MIPS cost performance category fact sheet. And most of the information I'm presenting today comes from that fact sheet. So there are some common features with all of the MIPS cost measures. They all have a payment standardization element. They all have some benchmarks. And then they also have an attribution process and are risk adjusted. So we'll talk just a little bit about each of those. So payment standardization takes place because of the regional differences in labor costs and practice expenses. Differences in the relative price of inputs in local markets is also taken into account for the payment standardization, as are the extra payments from Medicare in medically underserved and policy-driven payment adjustments, such as those in teaching hospitals. So the benchmarks, there's one single national benchmark for each cost measure. The benchmarks are based on the data from the performance period. So this does make it difficult to kind of know during the performance period how you're doing on cost. For 2019, the benchmark will be set based on data they received during this 2019 payment year, or year 3. The attribution is done at the individual level, so at that taxpayer identification TIN NPI. For groups participating in group reporting in other MIPS performance categories, so if you do a group MIPS report, your cost scores are going to be determined by aggregating the scores of all of the individual clinicians within the TIN. So it would be the individual MIPS eligible clinicians within the TIN. And just as a note here, the method used to attribute beneficiary costs to each MIPS eligible clinician differs a little bit for each measure. So I would again reference that fact sheet and also the specification sheet for more information on the attribution at the measure level. So there are each measure is risk adjusted as well. So this accounts for characteristics that can influence the spending and are outside of the clinician's control. All of the cost measures are adjusted for clinical risk. The specific methodology to risk adjust each measure varies. So again, I'd go to the spec sheets to get that. So risk adjustment is not the same as complex patient bonus, which is applied at the final score level and adjusts again for patient clinical complexity as well as some elements of social complexity. So just to start looking at a couple, it's at the measures. So the first measure, and this was in effect for 2018 as well, this was also a measure, the Medicare spending per beneficiary. This particular measure assesses the total Medicare Part A and B costs incurred by a single beneficiary immediately prior to, during, and 30 days following a qualifying inpatient hospital stay and compares these observed costs to expected costs. Expected costs of this MSBP episode are based on clinical conditions or procedure that triggers the episode, along with other factors that may influence costs but are not directly related to patient care. So just to kind of see this in a picture form, at the episode starts 3 days before a patient is admitted. So if a patient is admitted, they're going to look back 3 days to see what those costs were, and then the index of the admission, and then the discharge. After discharge, they're following that patient for 30 days, and that marks the end of the episode. So the MSBP attribution logic is each beneficiary episode is attributed to a single TIN NPI. The episode is attributed to the MIPS eligible clinician that bills the largest amount of the allowed charges. They call this the plurality of charges. And the minimum case volume is 35. And so we'll move on to the next one, which is the total per capita cost. This assesses the total Medicare Part A and B costs for a beneficiary during the performance period by calculating the risk-adjusted per capita cost for beneficiaries attributed to an individual clinician or group. So just to talk a little numerator and denominator. As you know, most measures, that's how they're calculated, based on a numerator and a denominator. So the numerator is the sum of the annualized risk-adjusted, specialty-adjusted Medicare Part A and B costs incurred by all beneficiaries attributed to an individual MIPS-eligible clinician or the individual eligible clinician in a group that is participating as a group. And the denominator is the number of Medicare beneficiaries who are attributed to an individual MIPS-eligible clinician or a number of all Medicare beneficiaries who are attributed to a group during the performance period. For the TPCC measure, the minimum case volume is 20. So the episode-based measures are kind of broken down into two different categories. So the first category are acute inpatient medical conditions. So they're based on episodes, and the episodes are listed here. So the first one is the intracranial hemorrhage or cerebral infarction, simple pneumonia with hospitalization, and the elevated myocardial infection or STEMI with percutaneous coronary intervention. So those are the three that relate more to inpatient. And just as an example for, or talk about the attribution for these inpatient medical conditions, the episodes are attributed to each MIPS eligible clinician who bills inpatient evaluation or E&M claim lines during a triggered inpatient hospitalization, or the stated the episode, and renders at least 30% of the inpatient E&M claim lines in the hospitalization. Episodes are defined by billing codes that open or trigger an episode. The episode window starts on the day of the trigger, and the end date varies by measure. Again, the specification sheets can certainly give you that detail. So just a picture of an attribution example for one of these measures. You can see that the 10D is where this patient would be attributed because they had the highest percentage of Medicare billing during that time. And this comes right from the cost measure, the information form or the spec sheet for this cost measure. And each of them have a diagram such as this. So the other episode group measures are more procedural related. So you have one related to cataract removal, knee arthroplasty, elective outpatient PCI, and lower extremity chronic critical limb ischemia, and screening and surveillance of colonoscopies. So these are all procedural based and would not necessarily include a hospitalization. So the attribution logic for these measures is that they attributed to each MIPS eligible clinician who renders a triggering service as identified by the HCPCS code in the CPT. The clinician rendering the services or the organization the clinician is billing under for the services is identified by the information provided in the provider tax number and performing physician field on the Medicare Part B physician supplier claim. So again, that kind of speaks again as a reminder maybe that there is no data submission for these measures. This is all taken off of your claims. So assignment of items and services to an episode. So there are some things to consider. They're furnished within a patient's episode window. They're based on clinical determination of whether a service is under the influence of the attributed clinician. Services furnished as a consequence of care, such as complication, readmissions, unplanned care, and emergency department visits may also be included. The episode group does not include clinically unrelated services. An example to that would be chronic conditions. So the minimum case volume for the episode-based cost measures, for procedural episode-based cost measures, it is 10, meaning 10 episodes must be attributed to the MIPS-eligible clinician or group for the measure to be scored. And then for the inpatient conditions, it's 20. So this diagram just represents what happens if you don't have any attributed cost measures. And if you look at underneath the reweighting, so if there are no cost measures and your cost measure category gets reweighted, it goes to the quality. So that would mean that your quality category goes to 60% and your cost category goes to 0. There's some other reweighting in this chart that might be applicable to other situations, but I thought this was a nice chart to share. So with that, I will end the didactic session. The contact information for all of us in the states is listed here. And Erin, if we can open up the line for question and answer at this time.
Of course, thank you. If you have a question, please press star then 1 on your touch-tone phone, and if you wish to be removed from the queue, please press the pound sign or the hash key. There will be a delay before the first question is announced. Once again, if you have a question, please press star then 1 on your touch-tone phone.
Hey, this is Reed Hauser with Stratus Health, and I was just going to interject and add to some comments you made, Mona. And I was thinking kind of at a higher level, why is it so important at this point to understand what's going on with the cost category? And one little item, sort of knowledge nugget that gets lost in this, is part of the legislation for the quality payment program and MACRA is really the name of the legislation, is that the cost category has to be set at 30% of the total score by the performance year 2022. And how CMS determines we get there, increasing it by 5 or 10% each year, they could choose to go directly to 30% if they so wanted to. But because it becomes, almost a third of your performance score, it's good to know kind of what's going on behind the scenes and why you're arriving at that category score.
Thanks, Reed. That's really important information. So it's going to become more and more heavily weighted on the cost, and part of that ties to trying to reduce the burden of reporting too, with this not needing any reporting.
Yeah, and it becomes sort of a black box without the information that you've presented here, Mona, but the good thing to know is people think like, well, they just give me the score for that cost category, but as you think through it, it's really kind of comes down to those actions that you take based upon that attribution and, how you're performing from a quality perspective. And so you do have some control over that cost, although it isn't as transparent as looking directly at a quality measure or doing a specific improvement activity or, promoting interoperability objective and measure.
And with that being said, there are things that you can do to affect costs, things like calling patients after discharge, making sure that they're okay, they don't incur maybe another emergency room visit during that time because of maybe a medication that was not prescribed correctly, or they have different meds at home than they were on at the hospital. But sometimes just post-discharge calls can help with some of that.
Yeah, so it's kind of the systems and processes that are based around these episodes that will impact the cost score.
Mm-hmm. Do we have anybody on the phone with questions?
There are no questions at this time, but once again, if you do have a question, that is star then 1 on your phone.
And I would remind everyone that the questions do not have to be cost category related. We will answer any questions related to MIPS or the QPP program in general. So it says, we do have something in the chat. It says, do you know if more measures will continue to be added in addition to the gradual weighting increase of this cost category? We don't know that for certain, but would not be surprised. I don't think it's by accident the measures that they're starting out with are those episode measures that probably are the highest cost or most costly at this time. But I don't know, Reed, do you have any insight on that?
No, CMS really hasn't provided any information as to what will happen in the next performance year. But if you kind of base the future forecast off of what they've done with other categories and, for example, quality measures, when they look at the data that they get for those cost measures, they're going to determine where are we doing well, where are we not doing so well. If everybody's performing quite well on a particular cost measure, they may say that just like a quality measure that it's popped out, that's kind of the vernacular they use, and they may choose to phase that out and replace it with a different cost measure. So they've been very responsive as far as looking at each year and determining how are we doing on a whole, kind of nationwide on the program, and then kind of changing things accordingly to emphasize and use different cost measures, just like quality measures, as different sort of policy levers to get people to focus in on different things rather than just doing the same thing from year to year. So they could stay constant, but I wouldn't be surprised if there's some changes or tweaks made over time, year to year.
Mm-hmm. Are there any other questions?
There are no audio questions at this time.
Okay. We'll wait a few minutes.
Maybe many of us are, I was going to say, maybe many of us are kind of coming off the reporting intensity there and just absorbing today, and a chance to kind of think this over and look at the cost fact sheet. And I did provide another link in the chat section there. So if you want to click on that, and then you can take what you've learned here and kind of browse through the cost fact sheet in your leisure. It's about, 24 pages.
Yeah,
but a lot of that, there's some tables and so forth in there.
Yeah. If anyone on the line wants to share any information about anything that happened during the reporting period that you think others could learn from, certainly that's open for discussion too, or any struggles people had, or maybe something that went really well.
Once again, that is star then 1 if you have a question or a statement.
I would share while we're waiting here to see if anybody would like to pose a question from our help desk perspective. So Stratus Health, and we cover the state of Minnesota, and then Mona's over in Wisconsin, and then we've got Michigan as well, Metastar and Empro. And on our side, it was relatively quiet, which was actually kind of a good sign. It meant that we've been in this program now. This is the third time we've done reporting. 2017, 2018, the second time really.
Yeah.
So CMS has been responsive as far as like modifying the way we report their portal, their web portal to do the reporting. So the fact that we had fewer questions was a good sign, I think, and most people got through it with the only questions I saw coming our way were more about changing passwords and using this new HARP system, which was kind of the evolution of the EIDM or Enterprise ID Management System from CMS to access the portal. So it was more those types of questions.
Yeah, we didn't have. I thought the reporting period went fairly smoothly from our end, but perhaps if somebody else had if there's somebody who didn't have that experience, share that. Okay. A quiet bunch today.
It could be that a lot of folks are just out shoveling today, and a lot of us had that snowstorm came through, and we're all tired from that, shoveling heavy wet snow. Who knows?
Yeah. I don't want to waste people's time if we don't have any questions to address. So one last call for questions, and give a couple minutes for people to either type them in the chat or get onto the phone.
Once again, for phone questions, that is star then 1.
Not seeing any questions in chat. Reed, are you seeing anything in chat
No, I think
that I missed?
I think we're relatively quiet, just like on the phone line. So no
Yeah.
questions here. Sounds like we could
Well,
probably wrap up a little early.
Yeah. I will thank everyone again for joining us today. We ask you to please take a moment to complete the brief evaluation that will appear when you close out of the webinar. Your feedback is much appreciated and is used to inform our future educational offerings and resource development. Today you will be automatically redirected to the evaluation. So thank you very much, and hopefully you can attend our next open office hours.
Thank
Thanks,
you, ladies
everyone.
and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.